So, this is my disclosures. So, thanks for the organizers for inviting me. It's a pleasure to prepare this talk. And did you know that vessels out of control is such a dedicated topic of research? So I found more than 4,700 matches putting in vessels out of control. And don't worry about this, I will leave the cat inside the bag, because after 2 weeks of reading, I realized that most of these readers focus on the topic of tumor-induced angioneogenesis. So this is the main topic of this retreat. And I ended up with the awareness, this is really complicated stuff, but there is a much knowledge of angiogenesis. And I will put the main topics in a line. It requires a highly regulated signaling, and it's hypoxia-induced increased expression of pro-angionetic factors. This leads to activation of endothelial cells and is an inhibition of neighboring cells. Metalloproteinases play a major role. They are degenerating, and this produces something like a gradient of stimulating factors. And this is how the vessel sprouts knew in what direction to grow. So, but this is knowledge from real angiogenesis, but maybe some of those principles are also true for hypoxemia in congenital heart disease. On the other hand, one of the topics is bronchopulmonary sequestration. And this is defined as a non-functioning lung tissue which has no connection to the normal tracheobronchial tree, has an independent systemic vessel supply, and the blood outflow is either to the systemic veins or to the pulmonary veins. And I think this is not correct, but in the literature, 2 forms are put together, the intralobar and the extralobar sequestration. But this is maybe complete different stuff. Over the last 150 years, there have been different theories of intralobar and extralobar sequestration. Fraction, excess, blood supply, traction in the course of infection. All these are major theories, as well as embryologic theories may come from the foregut, might have to do something with disruption of the tracheobronchial tree. I think we can put this together in 2 main theories. As we all know and have heard from my speaker, the lung develops very early in embryology, and we know from preterm babies that different diseases from different steps of the development. And it may be true that extralobar sequestration comes up early in the embryologic development and the first step of the development of the tracheal tree, if there is any disturbance in the very early embryologic development. I think we should divide. Intralobar sequestration is an acquired disease. It is associated with bronchial obstruction, with pneumonia and pleuritis. It's more frequently found in adults and is rarely accompanied by other congenital diseases. So maybe the development of a systemic arterial supply is secondary to angiogenetic growth factors, and these are those which are activated by hypoxemia and recurrent infections. And in contrast, the extralobar is a truly congenital disease. We found it typically in neonates. It's usually associated with other congenital malformations, and this may arise from the early primitive foregut. And my first case report I presented in the early 90s was a preterm baby with an extralobar sequestration. The treatment of time in the 90s was surgery to remove this by surgery. And nowadays, this is no longer the question. You can close this vessel, fix it. And nor did I found any complications in their own patients, nor did I found any hint in the literature that there's any problems if you close the extralobar feeding vessel. And in the adult population, there is more diagnostic effort. The CT is imaging of choice because there's always associated pulmonary pathology, and you can manage the disease either with sequestrectomy or thoracotomy, and this is mainly a question of access and the doctors. I think there are also a growing number of literature who did the treatment with artery embolization, and this mainly depends on the amount of accompanying lung disease and can be done in the cath lab as well. There's another entity. This is a anomalous systemic artery to the left lower lobe, and this is also present for the right lower lobe. And this is a congenital disorder without coexistence of a congenital heart or lung disease. And the affective lobe shows a normal lung parenchyma. It's a regular connection of the lobe bronchus to the main bronchial tree, and the pulmonary artery to this affective segment is missing, and this is normally no double supply. It's also a rare entity, and maybe nowadays easily detected by echocardiography, and the treatment is the same as an extralobar sequestration. You can close the feeding level in cases of volume overload. And there is no hint in the literature that this causes any necrosis or any other damage to the lung as well. More complex are those pulmonary AV malformations which bypasses the pulmonary capillary bed. And there are some conditions. It's a rare clinical entity, and without accompanying congenital heart disease, it's mostly associated with the morbus Randu-Osler. And those patients normally present with dyspnea and unexplained hypoxemia in the younger age. And there's also the same entity in patients with liver failure, in hepatopulmonary syndrome, which normally occurs later in life. And the other condition is after PCPC and the Kawashima procedure, as Oliver Schrimper showed in the last talk, and I will go deeper into this condition with the following slides. Which are the possible complications of pulmonary AV malformations? There are the neurological complications, cerebral abscesses, accidents, migraine, seizures, cardiovascular, pulmonary hypertension, high output cardiac failure, embolism, pulmonary hemoptysis or hemotothorax, and hematological in the cause of chronic hypoxemia, polycythemia. The role of the liver in the development of pulmonary arteriovenous malformation has been discussed extensively. We have heard about the role of VEGF and other factors, and there seems to be a disbalance of pro and anti angiogenetic factors, and also the missing clearing function of the liver with pro-inflammatory cytokines, which in the course leads to the development of new or reopened, this is unclear, pulmonary arteriovenous malformations. And also this imbalance of the pro and anti-angiogenetic factors is in the end is translated by those paracrine signaling involving VEGF and other factors. Concerning the morbus Randu-Osler, I will present some case reports because it's always a talk should give some impressions. This is a small infant. The only symptom is unexplained hypoxemia and a heart murmur. And the treatment in this patient is embolization of some of the malformations to control the hypoxemia. This is another patient, 13 years of age. It's his fifth intervention. Symptoms: severe hypoxemia, chronic cerebral abscess, and sagittus in the course of the abscess. And it's a really sick patient, and it's an ongoing story. This is a third example, newborn in 2010. The only symptom was unexplained hypoxemia and a heart murmur. The family history completely blank. So this is the first angiography showing this giant pulmonary arteriovenous fistula without much pulmonary bed in this lung. And our therapy was PA banding to control the hypoxemia, which worked very well. We followed up by some images, and unfortunately, the malformation grows proportionally in this child. And later on, the child, in addition, developed arteriopulmonary collateral arteries, a lot of. And we confirmed the diagnosis genetically, and the testing of the family shows grandfather, father, and brother are also affected in this family. At the age of 2 years, without any clinical event so far, we started closing arteriopulmonary collateral arteries in order to control hypertension in the right pulmonary artery. And at the age of 4 years, we had the first hemoptysis in this patient. We did further embolizations. In the meantime, the father suffered from massive abdominal bleeding and emergency surgery. So we have now a very sick family. At the age of 6 years, after another hemoptysis, we decided to close the fistulas by embolization. Unfortunately, some weeks later, another hemoptysis and resuscitation, and we ended up with a right-sided pneumectomy, which luckily we could discharge this girl 6 weeks after surgery, after a short time on temporary tracheotomy. And this is a Christmas letter I received some weeks later, and I think for this smile, this is why we also are engaged in pediatric cardiology. This is where we live from. Okay, more complicated is the arteriovenous malformation in patients after Kawashima procedure. This is a patient, 24 years of age, with severe hypoxemia, bilateral, bidirectional, partial cavopulmonary anastomosis, continuity of the hemiatzygos vein, and disruption of the inferior caval vein. And we have, it's not running, maybe you can click on the lower right angiography. Okay, does not matter. At this age, and the severity of the disease, we decided to close the left pulmonary artery in this patient. And this worked very well. This is now 2 years ago, and he clinically improved much from this procedure. Saturation is controlled, and he is in a stable clinical condition. But this is not the end of the story. We have some convincing evidence that the liver factor plays a major role in the occurrence of those pulmonary arteriovenous fist malformations in cavopulmonary anastomosis. If you have a classic Glenn anastomosis, those PAVMs occur only in the ipsilateral lung. If you have a bilateral bidirectional Glenn anastomosis, may occur in both lungs. And it also occurs bilateral if you have the Kawashima procedure and the absence of hepatic venous blood in the pulmonary circulation. Similar malformations occur frequently in patients with hepatopulmonary syndrome, and a liver transplantation also leads to recurrence of the PAVMs in those affected patients. Morphological PAVMs are characterized by greatly increased numbers of pulmonary blood vessels, and so it's convincing that this is a proliferation and neoangiogenesis which may play an important role. Concerning treatment, the only systematic access was the Boston experience. They identified 16 patients in an 11 years period which developed PAVMs in the mean 3 years after the Glenn anastomosis. They redirected the hepatic venous blood flow into the pulmonary circulation and found a clinical improvement in 11 of the 15 survivors of this treatment. And only 3 patients have been follow-up catheterizations demonstrating that really there was a regression of the PAVMs. Another 4 patients received re-interventions because severe hypoxemia lasted. And their conclusion was that patients with severe hypoxemia were less likely to benefit from redirecting the hepatic vein blood flow. This was the reason we chose for embolization in our 24-year-old patient. And the recommendation is to keep a high index of suspicion, to look for those PAVMs in patients after partial cavopulmonary anastomosis or Kawashima procedures. And if there is any hint of developing PAVMs, make your thoughts how to put hepatic venous blood flow into the pulmonary circulation. This is the same also Peter Evert's group just published from the Munich experience. In the other patient, pulmonary angiography is required to evaluate the size, the anatomy, and to guide the treatment for symptomatic malformations. And transcatheter embolization is a treatment of choice and can be repeated safely. And that's all I have to tell you. Thank you, Felix, for inviting me. And now your question, please.